All right, thank you everyone for joining us today for our South Texas Regional Family Medicine Grand Rounds. Our educational partner today is the South Central Area Health Education Center. Our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. All right, thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engaged in the session, registering for CME credit for each session, and for completing and submitting a session evaluation form. Today is May 1st, 2024, and the activity code for today is 10093247. You must register for each session by midnight in order to receive credit. Again, today's code is 10093247, and here's some information about that new system. All right, here's some information about accessing your CME transcripts. And some information about claiming that credit from the AAFP. Our Family and Community Medicine Grand Rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS, ACGME competencies, and the AAMC competencies. Our speaker today, Alyssa Gardner, MD, has no financial relationships with ineligible companies to disclose. And Dr. Nato will now introduce Alyssa. Dr. Gardner.
So please join me in welcoming Alyssa Gardner. She is one of our outstanding third-year residents. She completed her undergraduate studies at the University of Wisconsin in Madison, followed by medical school in Wisconsin. She made her way to South Texas for residency. And next year, she's heading north to be a faculty member at the Alaska Family Medicine Residency. So we're really proud of her for that. And we're looking forward to hearing her talk.
All right. Thank you for that introduction, Dr. Nato. Let's get started, guys. So today I'm going to be talking about the 2022 AAFP poem, answering the clinical question of does vitamin D reduce the risk of fracture in older adults? So these are some of the objectives for today's talk. We're going to hopefully have you be able to describe the results of the VITAL trial, be able to evaluate if the findings of this study are generalizable to your patient population. And then in the future, hopefully you'll be able to apply some of the key findings into your clinical practice. So just to start out by giving a little bit of context for this study, this poem is based on an ancillary study of the original VITAL trial. So I just kind of wanted to talk about the original VITAL trial, just to, give a little bit more insight into the kind of exclusion criteria and how they chose some of the patients for this study. So the original study was actually looking at whether supplemental vitamin D reduced the risk of cancer or cardiovascular disease. And these are kind of the results and the statistics that they got there. Basically, they did the study and then they plugged all of the data into meta-analyses that reviewed this study with many other studies on the topic, and ultimately found that there was significant reduction in cancer mortality, but not in cancer incidence or any of the cardiovascular disease endpoints that they looked at. So from that, they said, hey, we have this really robust set of data. Let's see what else we can pull from it. And so they decided to launch this ancillary study. And we're going to talk a little bit about the rationale for that. So an estimated 53.6 million Americans have osteoporosis, low bone mass, or both. And in the US, 2 million osteoporotic fractures occur annually. So quite prevalent, and the number is on the rise. So in the next 15 years, by 2040, they expect that number to exceed 3 million fractures annually. And this is a huge deal because it is really traumatic and, emotionally, financially burdensome for our patients, but also it puts a huge cost on the system. So $95 billion annually in taking care of these patients. And then when we kind of think about all of these bad things that are happening and trying to find a solution or ways to prevent or improve outcomes for these people, one of the things we've been using for a while is vitamin D. And so I thought this was crazy. In almost 13 years, the use of vitamin D supplementation increased from 5% to almost 20%. So if it's working, great. But if it's not, that's a lot of money that is going to like Costco vitamin D supplements. So this is kind of the idea behind, I'm assuming in med school, we all recall this calcium homeostasis loop. So the idea behind the vitamin D supplementation is that it's going to increase the amount of calcium that we can absorb from the diet. And that ultimately will hopefully reduce secondary hyperparathyroidism, decrease bone turnover, and make our patients happier and healthier. But does it work? We'll find out. So in 2011, the Institute of Medicine established kind of this blanketed statement saying that dietary allowances of vitamin D for 600 to 800 international units per day were what we should be doing. And there have since been studies that have shown that they agree with this. Some studies say that there's no effect of this, and some studies have even proven harm. So ultimately, this study set out to see if there was benefit and if there was harm, and kind of answer some of these questions. So this is the study design of the ancillary study, which again was pulled from that original VITAL trial, which stands for the vitamin D and omega-3 trial. It was a randomized control double-blinded trial. So that is one of those high quality pieces of evidence. And then it was a 2x2 factorial design. So for the visual learners, I have a picture on the next slide that kind of shows it divvied up a little bit more. But essentially of the total population, it was split into vitamin D versus placebo. And then from those two subgroups, they got omega-3 or placebo. And this study itself was just looking at the vitamin D versus placebo groups. They didn't really analyze whether the omega-3 fatty acids had any effect. And so again, very robust study, over 25,000 patients. And in general, the population included men over 50, women over 55. And then the exclusion criteria were patients without patients with a history of cancer were excluded, patients with a history of cardiovascular disease were excluded, and then patients with hypercalcemia were excluded. So again, helpful to know the original study just to kind of understand that a little bit better. And then also interesting to note, none of the patients were selected based on their fracture risk or their vitamin D levels, but they were able in post-hoc analyses to kind of look at those specific groups. So the endpoints of this ancillary study were to look at incident total fractures, non-vertebral fractures, and also hip fractures. And although this was not data that was originally studied, they basically went back and sent out annual questionnaires to the population, as well as doing some chart review retrospectively to kind of see if people had had fractures after the study was initially completed. So this is the breakdown for the visual learners. They started with tons of participants, so 400,000 people. And then as people were slowly weeded out because of their comorbidities, they got down to this pool of about 40,000. And then anybody who kind of within that time period developed issues or refused to reduce the amount of vitamin D they were taking if they were already taking higher levels of supplementation, all of those people were thrown out, and then we're left with the 25,000 that were then randomized. And this is the kind of 2x2 factorial design. So half of them went to vitamin D, half of them went to placebo, and then they split from there. And again, we're kind of just looking at the first split there in this study. So this is the demographic data, and I went a little crazy with the color coding here. So the blue is kind of what I boxed off as being what I considered like our patient population here. And then red is things that I said like, hey, that is not super applicable to our patient population. And then yellow was just fun stuff. So the average age of participants was about 67. I think that's pretty in line with the age of the patients that I see here at the Robert B. Greene. And then looking at the non-Black Hispanics, although this is not congruent with our population, that is most of our population. I would say like 50 to 60 to maybe upwards of 70% of our patients are non-Black Hispanics, and only 4% were in this study. And then the last piece that I thought was kind of in line with our population was the number of unintentional falls in the past year. So about a quarter of the participants had an unintentional fall in the last year, which I think that's maybe in line with the population that we see here. Kind of less congruent with our population is the BMI. So the average BMI of participants in this study was 28, so a little bit more on the lower side. And then the percentage of patients with diabetes was only 13% in this study. So again, I think we're like 50, 60, maybe 70% of our patients have diabetes. So just things to consider. Obviously, these are not like huge red flags that would make this data not applicable to our patient population, but just some things to consider. And then they also showed us basically of the patients who started the study, who was already on supplemental vitamin D. And so it was about 50-50 people that were already on some amount of supplemental vitamin D versus patients who were not. And then they also look at the baseline vitamin D level, which I think is really helpful. And there's going to be a little bit more on that later. But the average vitamin D level of patients in the study was right around 30, which is, at least by our lab standards, within the normal range. So this is just a cheat sheet for the statistics that we're going to look at. So the hazard ratio basically is just how often an event happens in one group compared to the other over time. Confidence interval, if it crosses 1, obviously does not really mean anything. And then the p-value is just how likely it is that the observed difference between the two groups is due to chance alone. So that was in the board review questions. I know we all already took boards, but for our PGY2s and PGY1s, that's coming in your future. So here's the most of the data from the study. So there were 1,991 fractures in 1,551 patients over a median of about 5 years. And then they went and looked at, again, the total incident fractures, non-vertebral and hip fractures. So for the total incident fractures, in the vitamin D group, there was 769 fractures. And in the placebo group, there was 782 fractures. So hazard ratio was almost 1, confidence interval crossed 1, and then the p-value was 0.70. So basically there is no difference between these two groups. And then when they went and looked at the other two subgroups, same thing. Hazard ratios were right about 1 for both of them. The confidence intervals both crossed 1, and then the p-values were like 0.5 and up. So no difference between these groups. And then they did just give a little bit more information about the kind of stratification of the vitamin D levels of the participants. So 25% of the patients had a baseline vitamin D level less than 24. And then 1.5% of patients had a baseline vitamin D level less than 12. And again, we'll talk about how that kind of panned out in the post hoc analyses a little bit later. But again, something else we were looking at is whether or not the supplementation of vitamin D is going to cause harm to our patients. And they did find no differences among the two groups regarding renal stones, episodes of hypercalcemia, or other adverse events. So at least from like a medical standpoint, we may not be harming people with this intervention, but again, with all the cost that goes into paying for medications and supplements and things like that, still definitely something to consider. This is just one of the graphs. So this is the one looking at the total incident fractures, and you can see across the time span, the lines are pretty much on top of each other. The graphs look very similar for the other two subgroups, so I did not include those in this study. But then we're going to get into the kind of 4 subgroups that they looked at in the post hoc analyses. And the first one is low baseline vitamin D. So I think for me, I was like, this is going to be very important. Looking at that demographic data at the beginning, they showed that like the average vitamin D level was right around normal. So if we're thinking, hey, if these people are starting out with lower vitamin D, does this study address that? And especially with vitamin D deficiency, we got to think about our Black and African American patients. Obviously, they have reduced cutaneous vitamin D synthesis, and potentially some of our Hispanic patients as well. People with obesity also kind of sequester that vitamin D in the fat stores, and we have a lot of patients that are also obese. And then postmenopausal women, older men, people with previous hip fractures, these are all people we can kind of think about. And I think people that probably account for 75+% of our population here that likely have low baseline vitamin D. But when they went and looked at all of the patients and kind of stratified the risk according to their baseline vitamin D, they found no significant differences in fracture incidence based on those levels. And then in the teeny tiny group of the 1.5% of patients, still a very robust group of over 400 patients, they saw no benefit for supplementation of the vitamin D. Another group that they looked at is patients with a high fracture risk, and they kind of defined this as patients who are taking osteoporotic medications or with a history of fragility fracture. They found no substantial difference between the groups as far as fracture incidence. And then another group, we frequently co-prescribe vitamin D and calcium, and over 20% or right at 20% of the participants were just taking calcium on their own in addition to the vitamin D. And there was no substantial difference in fracture risk for this population either. And then the last group that they looked at was basically bone mineral density. And this one, they did a separate ancillary study to look at. And so participants with a baseline vitamin D level below the median, they did have slight benefit on spine and total hip bone mineral density based on the DEXA scan, but the clinical correlation of that is not yet clear. So it might make us feel better when we look at a DEXA scan and things look a little bit better, but ultimately at this point, it still looks like patients are fracturing at the same rate. So that is kind of the end of the study that we'll be reviewing. And from that data, I was left a little bit not confused, but just wondering like, okay, if this came out in 2022, like why have we really not made changes yet? So I went digging in the literature, and I was also curious to kind of look a little bit more at like primary versus secondary prevention. Obviously, the study addressed, patients just with low baseline vitamin D, but they also addressed patients with history of fragility fracture with proven osteoporosis. So that is kind of including both primary and secondary prevention. And so this study just kind of validated my feelings that I was not totally sure what I was supposed to do with this data. It's not so much a study as it is just an opinion piece, but it said that authors of most guidelines and reviews on osteoporosis treatment often fail to distinguish between the primary and secondary prevention of fractures, which likely overestimates the treatment benefits in primary prevention and underestimates the treatment benefits in secondary prevention. So kind of just more information to say, you gotta still think about your treatment plan for your patients, and there is not necessarily a clear-cut answer at this point. So just to kind of review the prevention standards a little bit as well. Primary prevention is to just prevent disease, especially when risk factors are present. So in our patients we can use the low vitamin D levels or risk factors for osteoporosis, kind of thinking about interventions there to prevent progression. And then secondary prevention is going to be more of the screening. So the example is mammograms for breast cancer detection. But in this study, I think we can also think of it in kind of two different contexts. So you can think about like secondary prevention if you are diagnosing osteoporosis and trying to prevent those fractures down the line, or if they have a fracture already, trying to prevent a secondary fracture. And then tertiary prevention is going to be aimed more at optimizing treatment. And this is like with our HFrEF patients, getting them on GDMT and, trying to really optimize their status and prevent disability. And then quaternary screening is, I made this one up, quit while you're ahead, just trying to stick with the double letters here, but really just trying to stop over medicalization, do no harm. And that's kind of like another area that we're trying to get into here too, is just like, is this helpful or is this just increasing our patients' pill burden? And so our good friends at the USPSTF, I looked to them to see if they had kind of put out a guideline yet. And they are saying that the recommendation as far as vitamin D, calcium, or combined supplementation for the primary prevention of fractures and falls in community dwelling adults is in progress. It's being updated right now. So I was always told, like, don't change your practice recommendations based on a single study. You can kind of find a study to like recommend or be like in line with whatever you're doing, but really following like guidelines is kind of a good way to look at things. And obviously AAFP put out this poem, so you could consider it a guideline, I suppose. But I think this recommendation, we'll kind of wait to see what they end up saying with this, but I'm assuming this may change with the new evidence that is coming out that we discussed earlier. And then this is just another fun thing to review. I'm assuming most of you are very, very acutely aware of this with recently taking boards, but the people that we should be screening, women over 65, that's a grade B recommendation. And then postmenopausal women younger than 65, but at increased risk. So this is going to be smokers, excessive alcohol consumption, low BMI, obviously history of a fracture as well. Those are all people that you can consider screening early. And then for men, the USPSTF does not have any, they don't currently recommend it based on insufficient evidence. But there are some other guidelines that do, recommend for or against screening in male patients. So I just wanted to talk a little bit about kind of the secondary prevention. If you do diagnose patients with osteoporosis, some things that are proven. There are the two anti-resorptive therapies that are proven to reduce fracture risk are going to be bisphosphonates and then the monoclonal antibody denosumab. So bisphosphonates, weekly or daily dosing, orally, very poor absorption. So we want to instruct our patients to take them on an empty stomach with a full glass of water. Wait 30 minutes before eating, before laying down. And the mechanism for this is going to be to inhibit the osteoclast-mediated bone resorption. So I think we probably all have like some mnemonic in our head, but I was always told like osteoclast was for chew, but this says for chip. So it's inhibiting the cell that basically initiates the turnover of bone. Contraindications are going to be any esophageal pathology, stricture, achalasia, and then inability to be upright, just as this is going to increase the risk of esophageal problems. Patients with history of bariatric surgery have harder times absorbing this, so not going to see a lot of benefit with that. And then these medications we do have to consider the kidney function for, as well as hypocalcemia. And then the dreaded adverse effect of both medications is actually going to be osteonecrosis of the jaw. So it's important to maintain oral hygiene, regular dental care, and just be checking in on your patients. And then I think we were talking about this actually in clinic yesterday, the duration of treatment. So really the kind of safe answer is going to be 5 years of treatment. There are some studies that say you can treat for up to 10 years if patients are getting good benefit. And after you stop these medications, you're typically going to have some residual benefit for about 1 to 2 years after stopping. But it is probably about 1 year for you to see benefit of the medication. So slower on, slower off. And then if you have a patient who's non-ambulatory or who's expected to pass within the next 2 years, maybe not such a good idea to have them on this, extra medication that will likely not give them much benefit. And then from the studies and the evidence that I was looking at, they were recommending getting a DEXA scan 1 to 2 years after initiating therapy, just to make sure that you're seeing the result that you would expect, which is improved bone mineral density. And if you're not seeing that, kind of going back and reassessing and making sure that your patient does not have a different underlying reason for the low bone mineral density. And then the other medication that I just wanted to mention was, again, that monoclonal antibody denosumab. That is going to be a Q6-month injection, typically given in the clinic. And that is a monoclonal antibody against rank L. So basically like rank, I picture it as like a high school student, he's like ready to graduate, get his degree. And then like you give him his degree and he can go get a job. But in this case, they give him like a fake degree, and that blocks that receptor. So he can't go get a job. He can't do his job and, become like an adult osteoclast that can break things down. So sad for him. The contraindications to this, super nice because you don't really have to worry about kidney function. But because it is a monoclonal antibody, we have to think about infection. And then there is a lot more severe electrolyte derangements you can see with this medication. So it does require closer monitoring of electrolytes and, regular BMPs, just to make sure there are not issues. And the there we go. The hypo and hypercalcemia are going to be the biggest issues we typically see. Again, same super scary adverse effect of the osteonecrosis of the jaw. Typically, we still recommend it for like about the same duration of treatment, but unlike the bisphosphonates, this is going to be way faster onset. I read a study that said you can see improvement in the bone mineral density after 10 days even, but typically there's no benefit after stopping. So you're either going to start a bisphosphonate or decide that there's just no other treatment needed once you kind of run the course of this this medication. And then I'm not going to talk about the anabolic therapies, but teriparatide and some of the other options out there are also things. I think if we're getting to that point in the treatment plan, I would rather consult endo. So you can make your choice when you go out into the world. But essentially, this is what the poem highlighted. If you go to the AAFP website, this is the summary, the take-home point. Vitamin D is a good marker of ill health, but not necessarily a great treatment target. And this large study showed that supplemental vitamin D does not reduce the risk of fracture, even in patients with a low baseline vitamin D or a previous fracture, and that's a 1B. So pretty good evidence. So just things you have to think about moving forward. These are my references. That's all, folks. Does anybody have questions, concerns?
Dr. Gardner, can you hear me?
Yeah.
Thank you for your presentation. I might have missed you. Did you comment on, or did they mention about the gender differences in the study population? And what
They
type of
did not.
fractures are they counting for all of them?
Yeah, so they looked at the total incident of fractures and then non-vertebral fractures and hip fractures, but they did not comment on the gender difference, and that's very interesting. That may be coming in the works, or it may not have been included in this initial set of data, but that would be very interesting to see. Dr. Persani.
I have another question. Sorry.
Yeah, no, that's okay.
Did I know you have some patients are high risk, have history of fractures. Did some of them or all of them or evenly distributed DEXA baseline results available in the comparison groups? Or do they have DEXA results?
I'm assuming they have DEXA results at baseline. I don't recall if that was included in the methods at all, but I know they have done a separate ancillary study where they are getting like consistent DEXAs on people with the supplementation to follow that up. So I think there would probably be more data in that ancillary study than was included in this one. But I would assume they would have had to get that to be able to see if there was an improvement in the bone mineral density, which they say that they saw.
So you check a lot of vitamin D, so you find a lot of low ones.
Yeah.
You treat them, you think very often.
If people are already on vitamin D and they're loving it, I let them keep their vitamin D. But since reading this paper, it's very perplexing because every time we get a DEXA scan, it pretty much always says like, here's the impression, start your vitamin D and calcium. So historically, that's what I was doing. I think now I will probably have a little bit more of like a shared decision-making with my patients in regards specifically to fracture risk reduction. Obviously, they're saying that maybe it's going to improve cancer mortality, and there are other benefits that are still in the works with vitamin D. So I don't think it's all bad, but if you have patients who are like very not wanting to take medications, I think those are people that I would probably say, hey, this is one we can maybe leave off for now. It's split. It's a split group. Choose your own adventure.
One problem with it because you guys ordering the vitamin D. This study is not new.
Yeah.
Every few years they do a study and they find out there's no benefits and we keep doing the same thing.
Yeah.
My thing is that I tell my patient I don't order it. That's very important. Not ordering. Very important. When you order it, I have difficulty convincing my patient that they don't need it. For that reason, I just tell them that I'm not ordering it, I'm not treating it, that's have been, for the last 15 years. This my practice was like that because the knowledge was every few years they come and say this, just ordering.
Could you repeat the question or the comment? We couldn't hear it.
Oh yeah. So Dr. Persani is basically talking about the fact that, you know, this is not new data. There's been lots of studies that come out every couple of years saying that there's no reason to really be treating it. So he's kind of talking about the fact that we don't necessarily need to be drawing vitamin D levels, especially because then we're stuck with the result and our patients are asking for supplementation when really they may not need it. I think that's a great point, though. I only order vitamin Ds when Dr. Oskos is on service and we have patients with kidney disease and we're looking for hyperparathyroidism. But otherwise, typically the scenario I run into is getting a DEXA result that is recommending supplementation and being like kind of stuck with this blind recommendation that is clearly like a dot phrase on an impression.
But you just mentioned that you order vitamin D for patients that you think that they might have no vitamin D, for example.
Yeah.
So, and the vitamin D level will come back and it is low.
Mm-hmm.
Would they ever mention, would they benefit from vitamin D supplementation compared to the random population that you get vitamin D and it is low?
Yeah. So yeah. So the question was in the instance of patients with chronic kidney disease where we're getting the vitamin D level, it's coming back low, and whether or not there's benefit in those patients to supplementation. They did not comment on that population in the paper. Yeah, I think those are patients that I do typically treat. And again, I would have to do more research. I don't know if anybody else has information on that. We'll follow up on that.
I mean, that's different than a primary prevention thing.
Of course.
Then you're treating for a specific.
Yeah.
kind of-
Yeah.
Tradition of ordering vitamin D started in January.
Mm-hmm.
In the past, we did not order. And because you guys go into their location and see their ordering, now we are seeing all patients that are having vitamin D.
Yeah.
That we have to stop.
Yeah. Okay. Well, thank you guys. I hope you have a lovely rest of your day.